هي نيجاتيف بس مخالطه يعني لجوزها وابنها، ربنا يشفيهم باذن الله. فهي هتتكلم، مسجله لنا محاضره وهتقولها دلوقتي.
صباح الخير. First of all, I would like to thank زمايلي واخواتي واصدقائي واساتذتي على this kind invitation. كنت اتمنى ان احنا نكون مع بعض in person، ولكن الظروف مخلينا قادرين ان شاء الله في المرات القادمه باذن الله. What I'm going to speak to you about today is adrenal insufficiency in the neonate. And basically, one would think, well, most of the hormones are not essential for life, and this is actually true. ولكن this doesn't apply to the hormones that are produced from the adrenal gland. The adrenal gland is actually one of the organs that are really essential for life. And in fact, هنلاقي إنه في حالات الشوك والستريس الadrenal gland is one of the organs that receive preferential blood supply. So I'm going to show you 3 case scenarios for adrenal insufficiency in the neonate for 3 different causes, and we're going to discuss parts of them. Okay. So this is the first case. This was a baby. Just a second, best to hide notification. Okay. This was a baby born at term by elective C-section. Pregnancy was fine, birth weight, everything was okay. 3rd order, non-consanguineous parents, and no previous SIBT. And the problem was, as you can see from the pictures, that you can't really tell whether this was a male or a female baby. And in such condition, well, يفضل إن إحنا نسكت وما نقولش للأهل whether it's a boy or a girl until we're sure. So one could argue that this is either an undervirilized male with a poorly developed or bifid scrotum and micropenis, or it could be a virilized female with splenomegaly. And as you can see from the middle picture, that there is only one opening that might be إما إنها urethra if can male، يا إما إنها common opening for the vagina and urethra لو كان البيبي female. Okay. So this baby was fine until day 8 of life, when the baby started to have vomiting, mild dehydration, was found to be hyponatremic and hyperkalemic. Okay, the second one was a baby born again at term. Everything was normal, 1st order of birth, non-consanguineous parents, and the family was fine, no previous SIBT. This was a boy, and it was clear that this was a male baby born, healthy. Unfortunately, at the age of 5 hours, he started to have hypothermia and hypoglycemia, and sometimes that would be normal, and that resolved with feeds, and the baby was discharged home, and he came back again at the age of 3 weeks, well, with a picture of sepsis, copy, history of preceding respiratory infections, slow to feed, vomiting, and not gaining enough weight. And when we did some preliminary blood tests, he was found to be hyponatremic and hyperkalemic on 2 separate occasions, 12 hours apart, with a bit of impaired kidney functions. That might be pre-renal failure in case of because of the dehydration, and also a bit of metabolic acidosis. And this is the 3rd baby who was born at term, elective C-section with a good birth weight. But here the story was different. This was a very valuable baby. This family actually lost 2 previous SIBs, and this was the only live born. Both babies died at the age of 10 and 11 days with unknown hosts, but they were pretty the same. They presented with pretty the same picture that this baby presented with. The baby started on day 4 to be unwell, irritable, floppy. They were not sure that he was she was polyuric or not. And when they got the baby to the hospital, actually the baby was admitted with a loss of about 1 kilogram of weight in 1 week, and the genitalia was clearly female type, so this was a baby girl. A preliminary test showed hyponatremia again, hyperkalemia, and metabolic acidosis. So what were the 3 babies having? They were having the picture of adrenal insufficiency because of the dehydration and electrolyte disturbances that are very characteristic of deficiency of the egg. And the most important actually criterion to diagnose adrenal insufficiency is clinical find. So this is really important. They can present with shock hypoglycemia early after delivery, or it might become more insidious with poor feeding and failure to thrive. And of course, we all know that when we have hyponatremia and hyperkalemia, we start to think about the adrenal gland, especially in the presence of dehydration. We would be very lucky to find hyperpigmentation because this doesn't develop early. And a good clue to the neonatologist would be low baby عنده hypotension that is not responding to the normal vasopressor treatment that you commonly use in the NICU. Another good clue is that in the presence of good or normal renal functions, if you have a sodium-potassium ratio below 20, that is pointing strongly towards adrenal insufficiency. And if we go back to the embryology, well, the adrenal cortex in particular, واللي ده اللي هنتكلم عنه النهارده, is actually comes from the same embryologic origin as the gonads. Okay, so they're both mesodermal. The cortex starts to develop very early in life, as early as 4 weeks of gestation, and by the end of the first trimester, it is well developed. Okay, near the third trimester, the fetal adrenal gland is very large. It's about 10 to 20 times the size of the adult gland. And the main zone is what is called the fetal zone, اللي هي inner zone that produces the adrenal antigens المعروفين بالdehydrated androsterone and its sulfated form. Those actually are the precursors of placental estrogens, and they play a very important role in maintenance of pregnancy. And it is not until late in pregnancy, just before birth, that cortisol starts to peak properly. And after birth, the fetal zone undergoes involution, and the definitive zone actually proliferates into zona glomerulosa and vesiculata, and later on vesicularis develops as well. Okay, so if you look at the adrenal cortex, the adrenal cortex is the outer part of the adrenal glands, and it is mainly formed of the zona vesiculata, which is middle part of the cortex, and it produces the cortisol, our glucocorticoids. The glomerulosa is the outer bit, which produces aldosterone, and the inner bit next to the medulla is the reticularis that produce androgens. Okay, and the androgens are not really there until perhaps by 6 to 8 years of life. ودول اللي بيبقوا responsible for acne, adult body odor, axillary and pubic hair, and so on. So this is just to summarize the differences between the fetal and neonatal adrenal cortex. In the fetal cortex, there's very limited ability to produce cortisol and aldosterone as opposed to the adult one. All right, and the neonatal is the same as the adult. Okay, and if we think about the secretion of hormones, we all know that all the hormones تقريبا are under the process of what we call feedback mechanism of secretion. يعني احنا عندنا target hormone وعندنا controlling hormone from the pituitary and from the hypothalamus. Here we are mainly concerned with the hormones of the zona glomerulosa and vesiculata, aldosterone and cortisol. And they are both under the control of the renin, which controls aldosterone secretion. The renin is produced by the juxtaglomerular apparatus of the kidney, and the cortisol is under the control of ACTH from the pituitary. And the ACTH does not control aldosterone secretion, it controls cortisol. And so when the end product of the whole aldosterone or cortisol, whether this or that يعني are reduced, one would expect الحالة دي إن الرنين يبقى high as well as the ACT. Basics of endocrinology. Okay. طيب, a little bit about fetal cortisol. Fetal cortisol starts very low early in gestation, and it is not until late gestation that it peaks. We have a very high peak during and after delivery for a few hours, and this peak is really important with initiation of the process of labor and the maintenance of it, and the early hours of adapting to extrauterine life. وهنا المشكلة إن إحنا sometimes we fiddle with this. For example, مثلا elective C-section blunts the postnatal rise in cortisol. وده مهم قوي rise in cortisol للinitiation of surfactant, للclosure of ductus, للconversion of T4 to T3, all these processes. كمان preterm babies have a problem with the cortisol response اللي بتحصل during delivery. They have an attenuated response. Okay, so what about cortisol levels in neonates? The slides just have numbers not for you to memorize, and أنا نفسي مش حافظاهم. السلايد دي الهدف منها إن إحنا نبص على differences between the cortisol levels in preterm and term babies. So definitely preterm tends to have lower levels. But what is more important is that if you look at the range, you would find quite a high range. I mean, from 2 to 11, from 1 to 11. So what does it tell us? It tells us that a single measurement of cortisol tells us nothing in the newborn. It also tells us that an absolute value means nothing, okay? It tells us a third thing, that the diurnal rhythm, or famous diurnal cortisol rhythm, does not apply to neonatology, because this rhythm does not end until the second half of the first year and does not really mature until 3 years of life. So measuring the cortisol at 8 or 9 a.m. in a neonate doesn't give you that much. طب اما احنا بنبص على ايه؟ كل الهرمونز احنا بنبص على البالانس between the hormone and the controlling or the releasing hormone. يعني whenever a gland starts to fail in producing the hormone, let's say fail in producing cortisol, حتى لو الcortisol is still within the normal range of the lab, the pituitary should start acting, and you would expect to have a high level of ACTH. The same applies for any other endocrine gland. And what makes a diagnosis of primary adrenal insufficiency very likely is when you have a low serum cortisol, or slightly lowish, even within the normal range, but on the lower side of the normal range, with an ACTH that is above twofold of the upper limit of the reference range. Okay. Just a few words on neonatal cortisol levels. So the most important is that when you look at the cortisol level, think about the clinical state of child or of the newborn here. And the second thing is that if you have a serum cortisol within the normal limit in a patient that is under excessive stress, that doesn't mean that this is enough cortisol. It tends towards adrenal insufficiency. Okay, and this is what we call relative adrenal insufficiency, when we cannot produce adequate cortisol amounts for the degree of stress we are dealing with. And the most famous example for this phenomenon is the preterm baby. The preterm babies tend to have two types of adrenal insufficiency. The first one is within the first 2 weeks of life, and this is a transient form due to immaturity of the hypothalamic pituitary adrenal axis. And this is manifesting mainly as systemic hypotension. It's just simple and straight. And the second one is the late form of the adrenocortical insufficiency. And this is the more famous and the more serious. It comes during the second half of the first month because of what is known as relative adrenal insufficiency, limited ability to synthesize sufficient cortisol for degree of stress. And if stress عايزين excessive cortisol, والcortisol اللي عندي is not enough. The good clue دي اللي بنسميها the glucocorticoid responsive circulatory collapse. Preterm babies who have this form usually بعد ما بيكونوا stable, they start to deteriorate. They start, for example, to require oxygen in the absence of infection. ممكن نلاقي anemia, hypovolemia, و very serious نلاقي shock that doesn't respond to vasopressors or hypertension, that does not respond to vasopressors, but improves after glucocorticoid. And this is an interesting study that was performed on preterm babies with adrenal insufficiency, اللي هي late onset. These were the patients with controls كانوا preterm babies without late onset of adrenal insufficiency, and look at cortisol here and there, اللي هي dark dots, and the levels are almost the same. As if you look at the cortisol precursors, هتلاقيهم من أعلى في البريتيرم that were sick who have adrenal insufficiency. وده بيقول لنا إن الادرينال cortex is trying to make excess cortisol, but it is not enough. وهو ده اللي بنسميه late onset adrenocortical insufficiency of premature. And the treatment is glucocorticoid. Coming to types of adrenal insufficiency, there are basically two main subsets, primary and secondary. والsecondary مشكلتها في الهايبوثالاموس او في البيتويتري، او احنا بنعملها بالاكسوجينوس جلوكوكورتيكويد. اما البرايمري فهي المين فوكس اوف ذس ليكتشر، ودي يا اما acquired وده خلاص ما بقيناش نشوفه الحمد لله، او inherited. والinherited actually is either ان الجلاند دي did not develop so it is dysgenetic، وفي الحاله دي بالتالي مش تقدر تبروديوس its functions او الهرمونز بتاعتها. وcommonly الديسجينيتك adrenal cortex بيبقى معاها dysgenetic gonad لان هم جايين from the same embryological origin controlled by the same transcription factor for development. The second subset is one of the enzymes that are responsible for synthesis of cortisol and aldosterone are not working. ودي most famous example is the congenital adrenal hyperphysia. The third problem is in the gland بتطلع الهرمونز لكن the body is not responsive to these hormones وبالتالي دي end organ resistance أو impaired steroid responsiveness. So I'll start with the enzymatic problems اللي هي most famous of which is the congenital adrenal hyperphysia due to 21 hydroxylase deficiency that constitute more than 95% of cases. This is an enzyme that's responsible for production of cortisol and aldosterone. And so when this enzyme is not functioning, one would expect ان احنا يبقى عندنا low cortisol and low aldosterone في البيبي. At the same time, the substrate would accumulate. So 17-OHP would be accumulating in high amounts. ولأن the side way of conversion of 17-OHP to androstenedione and testosterone يعني باختصار to endocrine is patent and is working اللي هو الانزيم اللي اسمه ليز, one would also expect the androgens to be elevated. وبالتالي حالات ال CAH 21-OHP what you would find is low cortisol, low aldosterone, high 17-OHP, and high androgens. So going back to the first case, this was an under-virilized male or a virilized female with a Addisonian crisis on day 8 of life. The ultrasound confirmed the presence of uterus and ovaries, and the karyotype was female. So we did 17-OHP, which was on the higher side of normal. Don't look at the lab. احنا عندنا كتير cutoff في neonatal period اللي هو 10 or 17-OHP. If it exceeds 10, this is high. If it's less than 10, this is normal. Okay? فبالتالي احنا لقيناه 10, so it was slightly, يعني tending to be higher side. ففكرنا ان احنا نعمل the rest of investigations اللي هم الكورتيسول والACTH and aldosterone and renin. If the diagnosis was as we expected, one would expect the cortisol to be low, the ACTH to be high, aldosterone to be low, and the renin to be high. And what we found is that the cortisol was normal or slightly on the higher side, and the ACTH was very high, so more than double the normal, which tells us something. It tells us that this cortisol of 25 or 29 is not enough. This is low cortisol for the baby. At the same time, we could not have an aldosterone for one reason or the other. احنا عارفين الأسباب كثيرة, لكن we had a high renin. But that what it tells us that aldosterone is not enough. So what we concluded is that we are having a state of cortisol deficiency and aldosterone deficiency with slightly high 17-OHP and a virilized 46XX. So we did further the androgens.
يا دكتورة نرمين معانا لايف لو في حد عنده أسئلة.
So this is a virilized female with high 17-OHP, low cortisol, high ACTH, low aldosterone probably, high renin and high androgens. We wanted to confirm whether this is a congenital adrenal hyperplasia or not. And the way to do this is the ACTH stimulation test. This is a test that is done to confirm the diagnosis of CAH and also the diagnosis of adrenal insufficiency. But you cannot do this test if you have a sick newborn, and preferably you have to wait until the neonatal period is over to do the test. And my advice is that do not postpone treatment in case of emergencies. And furthermore, if you withdraw your blood tests, go ahead and treat until you get the results back. So do not wait for the results to be back. So we did, after the neonatal period, the ACTH stimulation test for this girl. And we did not actually حرمناهاش من treatment. We started treating her until she was stable. She passed the neonatal period and further did ACTH stimulation test later on when we were able to stop the treatment for some time. The ACTH is a dynamic stimulation test is a dynamic test. So you give ACTH and you see the response of the adrenal cortex. If the adrenal cortex produces enough cortisol, and by enough I mean it has to rise above 18 micrograms per deciliter, then this is not adrenal insufficiency. What about CAH? If the cortex produces high levels of 17-OHP that exceeds 10 nanograms per ml, then this is excessive 17-OHP, which confirms the diagnosis of congenital adrenal hyperplasia. So let me sum this up for you. To diagnose or to confirm the diagnosis of 21 hydroxylase deficiency when you're doing ACTH stimulation test, you need to have very high 17-OHP. And to diagnose adrenal insufficiency with ACTH stimulation test, you have to have a low serum cortisol, and by this I mean a peak that is less than 8. And we did that for the birth. She had a baseline 17 OHP of 11, quite high, and a post-stimulation of 15.8, that is exceeding 10 nanograms per ml, confirming the diagnosis of congenital adrenal hyperplasia due to 21 OHP. Furthermore, the levels, as you can see, came down nicely with treatment. So what was she having? She was definitely having CAH, 21 OHP deficiency. Okay, so back to case number 2. Case number 2, this was the boy, clear male genitalia with Addisonian crisis on a 3rd week of life. So, I mean, I was told when you apps, you think of sepsis or cardiac problem or an inborn error of metabolism. So we did that and we all came back normal. And then please do not forget to think about adrenal insufficiency. So we thought of doing 17 OHP and it came as normal on 2 occasions as well as androgens. So because 17 OHP is normal, this is not 21 hydroxylase deficiency. And because androgens normal also, again, is towards the not being CAH. We further proceeded to cortisol, ACTH, aldosterone, and renin. And what we found is that cortisol within the normal range, but on the lower side, with a very high ACTH. So it tells us that this cortisol is not enough. And that is why the pituitary is starting to push more cortisol production, but it is failing, the adrenal is not responding. At the same time, the aldosterone is low, frankly low, with high renin, so the aldosterone produced is not enough in that boy. We further did an ACTH stimulation test after the neonatal period, which confirmed adrenal insufficiency because he had low cortisol at baseline and after stimulation. The peak was less than 18. It also excluded congenital adrenal hyperplasia due to 21 OHP because the 17 OHP post-stimulation ما كانش عالي، كان أقل من 10. Okay, so what is this boy having? This is definitely not secondary because the ACTH is high, so the pituitary is functioning properly, and it is not acquired. Which one of those? In case of impaired steroid responsiveness, this is an end organ resistance. Yani, the gland is functioning properly, but the receptors are not responding. In such case, one would expect the hormones to be high. So this is not the case because the aldosterone and cortisol were not high. This is not CAH because the 17 OHP was normal at baseline and after stimulation. So this is dysgenesis. The adrenal cortex is not functioning properly, and thereby it is not producing enough cortisol and aldosterone. This is commonly a mutation in one of the transcription factors involved in the formation of the adrenal cortex as well as gonads because they are produced from the same origin. The most famous is the DAX1 mutation that causes adrenal hypoplasia, which is usually X-linked, so picture of adrenal insufficiency, and it causes also hypogonadism. And going through the progress of this boy, actually he continued to have repeated hospital admissions with Addisonian crisis, and he did not develop puberty when he was 14, and that confirmed the diagnosis, and the mutation was done. It was found to be this form of hyperplasia. Whether it is a hypoplasia or hyperplasia, the treatment is more or less the same. In case of Addisonian crisis, you tend to replace with intravenous, and when the child is stable or the baby is stable, you give the maintenance treatment in the form of hydrocortisone, mineralocorticoids, and sodium chloride for the hyperplasia to grow. What I need you to look at in this slide is the dose of hydrocortisone. If you will notice, it's slightly higher in case of hyperplasia, and the bigger part is given earlier, between 12 to 3 a.m. as opposed to 7 a.m. in case of hyperplasia. And the reason we do this is that this is the circadian rhythm for ACTH and cortisol. The ACTH starts to rise around 4 a.m. and the cortisol follows thereafter. وحالات الهايبربليزيا احنا مش المشكله بس الديفيشنسي of cortisol and aldosterone. We have another problem on top اللي هو الandrogens, excessive androgens. So we don't want to suppress excessive androgens علشان كده بنحاول ندي the bigger dose in the morning very early قبل ما ال ACTH starts to rise. Third baby is the female baby. That was a complete female baby, a very valuable one. A family has lost 2 kids. and came with a picture of adrenal insufficiency. So we proceeded more or less the same way, and the metabolic screen came to be normal. 17 OHP and androgens were performed, despite the fact that she was not ambiguous, and they came to be normal, excluding congenital adrenal hyperphysia. So the next step would be to have cortisol and ACTH, and they were both normal. So as long as the ACTH is normal, then the cortisol is enough for the degree of stress. What we found is that she was having excessively high levels of aldosterone وكمان high levels of renin. I mean, لو فكرنا في الفيدباك، لو الالدوستيرون is high, the renin should be low. But what if both are high? What does this tell us? It simply tells us that the renin is not sensing this high aldosterone, so as if it's not there. Anyway, because she was presenting with Addisonian crisis, she started the same protocol of management of hydrocortisone and mineralocorticoid. بس كان الغريب إن هي she required excessive amounts of sodium to maintain her serum sodium. So what can she be having? She's definitely not secondary لأن ACTH بتاعها is normal هو الcortisol. She's not acquired. She's not congenital adrenal hyperphasia لأن 17 OHP والandrogens normal والcortisol والACTH normal. She's not adrenocortical dysgenesis أو hypoplasia لأن ACTH والcortisol are normal. However, she's having what we call impaired steroid responsiveness علشان despite الالدوستيرون العالي الرنين كمان عالي. So we started withdrawing the hydrocortisone and mineralocorticoid and we replaced her with excessive huge amounts of sodium to maintain her serum sodium as well as potassium chelators اللي هي الصوديوم كوليسترين اللي هو صوديوم ريزونيوم. الصوديوم ريزونيوم is actually preferred في الحالات دي عن الكالسيوم ريزونيوم لأنه it swaps the sodium for potassium فit treats both hyponatremia and hyperkalemia. And she's continuing على فكرة البنوتة دي continuously thriving الحمد لله despite يعني some hiccups كده ودخول المستشفى بadrenal insufficiency. She's now 3 years of age. And this is what she is having. She has type 1 pseudohypoaldosteronism, and there are two types of the disorders. One is renal and the other is systemic, and the systemic is more severe and it tends to affect the lungs, salivary glands, independent pictures زي cystic fibrosis. So they present with the same picture of adrenal insufficiency, hyponatremia, hyperkalemia, ولكن الفلو هو الرنين العالي والالدوستيرون عالي with normal cortisol of 17 OHP. And the differential diagnosis is the adrenal hypo and hyperphasia. And the difference whether it's renal or systemic, well, clinically, renal سهل إنه يبقى controlled, systemic أصعب, and you can do genetic testing. وفي آخر slide بس عشان أقول لكم إن there are many more cases other than what I have presented في حالات الadrenal insufficiency, and this is just a list that doesn't include اللي هم genetically known دلوقتي. And I'm just here to tell you that whenever you need help, you can call the 911 team. We would be very, very glad to help you. And thank you again so much for your time and attention.
شكرا دكتورة نرمين على المحاضرة الجميلة دي. انا ما كنتش عارف ان انت لايف معانا لما قالوا لي مسجله
صباح الخير.
لايف معانا. هي لسه معانا. ازيك؟ الف سلامه وربنا يسهل باذن الله ما تلقطيش العدوى. عزل بس ما تعبرهمش خالص.
انا اللي طلعت خسرانه في الموضوع ده.
ربنا يخليهم لك. محاضرة جميلة جدا. واحنا بالمناسبة يعني احنا كان عندنا حالة ان الدكتور هشام معانا برضو كانت سودو هايبو الدوستيرونيزم والصوديوم والصوديوم العين وصل ان العين كان بياخد 18 ملي ايكويفالنت صوديوم تو بي كنترولد يعني من هايبوناتريميا، وان المينرالكورتيكويدز بياخد جرعات عالية قوي، كان بياخد كل 3 ساعات. وكان عنده حالة تانية سيب داس ما كانش معروف الحاله ماتت نيونيتال بيريود. الثاني حاله كانت متشخصه كونجنتال ادرينال هايبربليزيا غلط، وكانوا بيعملوا لها دياليسيس ودخلت في سابسيس اند دايد، وده كان العيان اللي اتشخص صح، كان الرينين بتاعه عالي، وكان فعلا مشي بعد كده على الصوديوم العالي الجرعات العاليه قوي دي، وفعلا هي واز سيفد يعني. شكرا نرمين. حد ليه اي سؤال؟ شكرا نرمين. اتفضلي نرمين.
اولا طبعا بشكركم وبشكر اساتذتي وزملائي، وكان نفسي اكون معاكم بس غصب عني، وبعدين بعتذر عن الكلب اللي كان عمال يهوهو لان احنا جبنا كلبه ودي كانت اخر حاجه احنا ناقصينها الحقيقه وقت الكوفيد. انا بس عندي a couple of comments بالنسبه لل 17 OHP measurement. طبعا هو ده الاول طول بنفكر فيه او بيتريز السسبشن بتاعنا للسي اتش. مهم قوي لما يتعمل بعد الدي 3 of life، لانه قبل الثيرد day of life falsely elevated. البروبلم الثانيه في البري-term babies ما بيبقاش accurate and we have to wait until the baby is term and repeat the 17 OHP. البريماتوريتي والسبسس بتالتر كل الهرمونز including الثايروكسين هرمون secretion. وطبعا السيكيو ثايرويد سيندروم ده اللي كان بيتقال عليه زمان لسه موجود وبنعتبره هو السبب الرئيسي مثلا. السكند كومنت بالنسبه معلش طبعا انا بشكر مها ودكتوره مها حسن ويوسف على الهايبوغلايسيميا. انا عندي بس هقول كومنت صغير بالنسبه للجروث هرمون في الكريتيكال سامبل. احنا ما بناخدش بيه نهائي لو بعد الفيرست 28 days of life. يعني if it comes low we just disregard it وما بيبقاش له اهميه. تعليقا على الكومنت بتاع استاذنا الاستاذ دكتور هشام على الانسولين ليفل وقت الهايبوغلايسيميا. احنا في الاندوكراين بنستخدم الكات اوف 40 ملي جرامز فور جلوكوز، وثيوريتيكلي سبيكينج اكشلي لو في بني ادم البلاد شوجر بتاعه اقل من 54 الانسولين should be really undetectable. وانا بستخدم الكات اوف اقل من 2، يعني whenever there is hypoglycemia المفروض ان البروبر ريسبونس ان انا الاقي الانسولين اقل من 2 if not 0 والسي بيبتايد مش باينه. لو لقينا الانسولين 3 for example في وجود hypoglycemia this is considered an improper high insulin level that should be investigated. فقط لا غير، ما عنديش غير كده و thank you so much. كنت اتمنى اكون معاكم بس السنه الجايه ان شاء الله.
دكتوره نرمين.
ايوه
سامعيني؟ صباح الخير.
صباح الخير استاذه دكتوره نهال، ازي حضرتك؟
ميرسي جدا يا نرمين على المحاضره اللطيفه دي. انا بس كان ليا سؤال.
اتفضلي.
طبعا انت وضحتي الترانزينت اند ليت اونست ادرينال انسفشنسي في البريماتيور بيبيز. انا بس هو كان سؤالي، طبعا احنا البريماتيور بيبيز commonly to encounter hypoglycemia and hypotension. بالنسبه للكلينيشن بقى اللي هو البراكتيشنر امتى يسسبكت ان هو يسيرش فور adrenal insufficiency، وايه what about the efficacy and the duration of treatment with glucocorticoids in the preterm baby؟ ده بالنسبه للبيبيز اللي احنا عندنا في النيكيو، فممكن لو سمحتي تقولي لنا.
في تو كلوز للادرينال انسفشنسي. الهايبوناتريميا والهايبركاليميا ده اهم element يخلينا نبتدي نفكر ان في ادرينال بروبلم، لانه الهايبوغلايسيميا ممكن تيجي مع السبسس، وكمان الهايبوغلايسيميا بانس الكورتيسول ريسبونس. فبالتالي الهايبوغلايسيميا مش accurate indicator. الاكيوريت indicator ان انا الاقي هايبوناتريميا with هايبركاليميا، ومش لازم الاقي بوتاسيوم 7 و8. انا كفايه قوي ان انا الاقي بوتاسيوم 5.6 5.7 5.8 with the presence of hyponatremia. فده يخلينا على طول نشك ونفكر. كلينيكالي الهايبوتنشن اللي بتبقى not responding للإينوتروبس والفازوبريسرز اللي احنا بنستخدمها في النيكو زي الدوبامين والبيوتامين والنفرين، لو فيها ريسبونس على طول دي كلو كويس جدا لوجود adrenal insufficiency اللي هي late onset adrenal insufficiency. another clue زي ما قلنا ان احنا نلاقي ان البيبي كان ستيبل وسبسس فري وابتدى يرجع تاني يحتاج اكسجين، او يحصل مثلا ري اوبننج للدكتس، او يحصل ريفراكتوري انيميا او هايبوفوليميا. مش اخر نقطه هقولها انه مش هندور البيبي لو سحبنا البلد tests for the hormones بالتحديد الكورتيسول والاي سي تي اتش وال17 OHP، وابتدينا glucocorticoids and mineralocorticoids because they can always be stopped at any time. whatever بقى it's a sepsis it's a late onset adrenal insufficiency of prematurity او suspected adrenal insufficiency. وبعدين نمانج. لو احنا عايزين نفكر نبتدي من الاول البرايورتي للمينرالوكورتيكويدز. دي نمرة 2. ثالث حاجة بالنسبة للليت onset adrenal insufficiency of prematurity اللي هتحتاج glucocorticoids, they usually respond very quickly and they might take glucocorticoids for 10 to 15 days maximum, وبعد كده خلاص they can easily get, you can easily get them off.
شكرا دكتور نرمين وميرسي قوي. ودلوقتي بقى باذن الله هنرحب باستاذتنا واستاذه الدكتوره توحيده، شرفتنا، وهي كانت يعني قلقانه في موضوع كورونا، بس هي اصرت انها لازم تحضر معانا وتشاركنا مؤتمرنا وفرحتنا، وانها تبقى حاضره الاستاذه الدكتوره ليرين محاضرتها، يعني قالت لازم احضرها، وانا سعيده انها حضرتك موجوده معانا، ورغم كل الظروف قدرت تيجي، وباذن الله كده بقى هنسمع من حضرتك تقديم مع ليرين. بس انا هقدم بس الاول محمد حسين، مدرس اطفال ونيوناتولوجي، هيقول لنا كيس برزنتيشن وستريكتد تايم بقى يا محمد عشان الوقت.
بسم الله الرحمن الرحيم. First of all, I want to show my thanks to Professor Hisham Awad, Professor Nihal Raggal, and Professor Safa Shafiq for giving me the opportunity to share a case in this conference. I'm going to tell a story, which is a very short story, inshallah, for this pretty baby. She's a female patient, 38 weeks of gestation, third order of birth of non-consanguineous marriage,